coming up in this episode. Now, in terms of increased tone and also in terms of the tremor, if they're not immediately obvious, then distraction can help to bring these out. So, what does that mean? I like to do it by asking the patient to move their head side to side. So, just laterally rotating the head to the left and right back again. Or conversely, other things you can do is ask the patient to draw circles with their contralateral arm, like this if you're watching on video. Or you can ask the patient to perform some form of cognitive demanding task, such as stating the months of the year backwards. And often in early cases, there may be no tremor and no increased tone at rest. But then with this distraction, whatever distraction maneuver you choose to go with, it then brings out the tremor and it brings out the increased tone. And that's a really important point to know about. Hello, and welcome to the next installment of Riisfeldt Neurology Education, a not-for-profit, free open access project with a philosophical touch, exploring all areas of clinical neurology, meant for medical students through to neurologists and any health professional caring for patients with neurological conditions. I'm your host, Tom Riisfeldt, a neurologist, epileptologist, and neurophysiologist and neuromuscular specialist, and also a physician, philosopher, and bioethicist. And today we have the first episode I'm excited to announce, which falls into the Movement Disorders and Parkinson's Disease series. And it also includes the Clinical Methods series. And it's titled Extrapyramidal Examination Theory with Pearls and Pitfalls. And that's why you'll notice that the background is a different color. It's a silver gray color because that's the color of the awareness ribbon for the Awareness Day for Parkinson's disease and related extrapyramidal disorders. A legal disclaimer before we begin. The content of this episode is for educational purposes only. So let's dive into it. Firstly, an overview of the components of the extrapyramidal examination. Some of the core components of the extrapyramidal examination have already been addressed in the preceding episodes on Riisfeldt Neurology Education, addressing the routine neurological examination. So please refer to the cranial nerves examination videos and the upper and lower limb neurologic examination videos for further details here. This includes higher center screening assessments, tone in the arms and in the legs, extraocular movements, including range, saccadic intrusions into smooth pursuit and slow saccades if tested, and gait. So taking a step back, fundamentally, what do we actually want to evaluate for in the context of an extrapyramidal examination? Well, firstly, let's think about the core clinical components of Parkinson's disease. So as many of us would already know, that consists of bradykinesia, and in addition to that, one or more of rigidity, rest tremor, or postural instability. So they're the four core symptoms of Parkinson's disease, and you need to have bradykinesia, and in addition to that, you need to have one or more of rigidity, rest tremor, or postural instability. Often as a fifth component, a positive levodopa response is also included in terms of the core diagnostic features for Parkinson's disease. In addition to these core criteria, there are many secondary supportive aspects of Parkinson's disease which are amenable to examination, so we'll be discussing those in this video. But extrapyramidal syndromes are not limited to Parkinson's disease. There's also the atypical Parkinsonian syndromes, or the Parkinson's plus syndromes, the three main ones of which are PSP, progressive supranuclear palsy, MSA, multiple systems atrophy, and CBD, corticobasal degeneration, or some people say CBS, corticobasal syndrome. And there are also a number of related cognitive neurodegenerative syndromes, in particular DLB, dementia with Lewy bodies, which have strong extrapyramidal features, and they all also form part of the differential diagnosis. So when we're examining a patient who has extrapyramidal features, not only are we looking to make a positive diagnosis of, say, typical Parkinson's disease or idiopathic Parkinson's disease, we also want to be on the lookout for any atypical features that might actually sway us towards one of these other diagnoses instead. And there are some other components of the neurological examination which are essential here to help make these delineations. So looking for cortical defects, especially apraxia, cortical motor and cortical sensory deficits, in addition to assessing for other cortical higher centers domains, so executive dysfunction, neglect. Also looking for ataxia, which we've discussed in previous episodes, and also looking for orthostatic blood pressure measurements for a measure of autonomic cardiovascular dysfunction. What else are we trying to achieve in an extrapyramidal examination? Well, things are a bit different if the patient has already received a diagnosis of Parkinson's disease, for example, and if they're already on treatment. Because in that instance, we want to elicit whether the patient has had a good treatment response, and we want to make an assessment as to whether the patient is currently in a good on period, whether they are in an excessively on period, or if they're dyskinetic, in other words, or conversely, if they're off. So if they're hypokinetic, or as an extreme, whether they are frozen. So the way that I like to approach an extrapyramidal assessment is, as you may have guessed, to adopt a top-to-tail approach. Even though this is an examination episode, I'll quickly mention some of the historical features to elicit on your history, because I can't think of a better place to mention them at the moment. So some key features in the history that you want to ask for, which are difficult to examine for directly, are features of REM sleep behavior disorder, so rapid eye movement sleep behavior disorder. So that's if someone is, rather than being paralyzed during their rapid eye movement sleep to prevent them from acting out their dreams, they lack the atonic muscular inhibition during REM sleep, and so they may appear to act out their dreams. They may be punching or kicking or other parasomnia motor behaviors that may manifest, which a bed partner may be aware of. Also, other sleep-related problems that are common in Parkinson's disease are problems like insomnia, daytime sleepiness, and fatigue, although of course they're very non-specific findings. Also, some gastrointestinal problems, namely constipation is a key one. And then also some autonomic functions affecting the genitourinary system, so urinary urgency or frequency, or in a male erectile dysfunction, or in either gender decreased libido. Also falls, depression, and also visual hallucinations. And they're important in particular in patients who are, say, on treatment and may have psychotic features in the context of levodopa or some other anti-Parkinsonian treatments. Or, of course, that's a significant finding in some of the atypical Parkinsonian syndromes, and in particular also in dementia with Lewy bodies. Then don't forget orthostatic hypotension, postural hypotension. I'm listing this at the beginning so that you don't forget about it. And then let's dive into the neurologic assessment. So, firstly, higher centers screening. I won't go over the entire higher centers examination because that will be a component of a soon to come episode to Riisfeldt Neurology Education. But essentially, you'll perform your screening assessment, and if that's insufficient, so if it's not obvious that there's a deficit, or if it's a normal screening and you want a more in-depth assessment, or if there's a problem but you haven't quite really precisely defined it and the patient requires more extensive neuropsychological or neurocognitive evaluation, then you can refer the patient for that with a neuropsychologist. And they then do a really, really detailed assessment that takes about 3 hours to perform. In addition to that, it's not quite higher centers, but I'd bundle it together. So a brief assessment of if the patient has a low affect, so that would be part of the mental status examination from a psychiatry perspective. And also if the patient is obviously responding to visual hallucinations in the room is important. And then I would also include primitive reflexes here. So these are very non-specific, but they can be indicative of a neurodegenerative process affecting the cognitive system or the extrapyramidal system. And there's quite a few of these, but the main ones that I like to look for are a glabella tap. So that's tapping in the glabella region, just in between the two eyes like this. And the normal response is that the patient may blink once or twice, but then they should stop blinking. So you continue tapping and the patient does not continue blinking. Whereas an abnormal response is the patient blinks with every tap, but they keep doing it. So you tap 5, 10, 15 times, and they'll just continue blinking every time that you tap on their glabella. And it has to be not really, really strong, but not too weak either. It should be a decent tap. The other two that I like to look for are the grasp reflex. So that's when you stroke the palm of the hand like this. And so you just do a nice gentle diagonal movement across the palm of the hand, and you see if the patient grasps onto the hand. And the other one you can do is the palmomental reflex. So that's similar, but a bit different. So you're doing a scratch. So you use the fingernail and your thumb, and you do a scratching movement more in the slightly more proximal part of the palm, just distal and just medial to the medial border of the thenar eminence. So just about there, if you can see on the video, if you're watching along on video, and you just do a scratch. And what you're looking for is a small, sometimes it can be difficult to see, so you have to look closely, a small little twitching movement on the side of the face, lower down in the lower face near the mentalis. So that's why it's palmomental. You're scratching the palm and you get this reflex twitch in the mentalis muscle, the palmomental reflex. So all three of these reflexes are highly non-specific because they are really frontal release signs in a sense. So you'll know that for some of these reflexes, especially the grasp reflex and some of the other primitive reflexes, we see these in the pediatric setting, especially in neonates and infants, and they have an evolutionary basis. And then as we age and we get out of the neonatal and the infantile period, these primitive reflexes go away. But what we see in some neurodegenerative conditions, including extrapyramidal conditions that we're talking about in this episode, with these frontal neurodegeneration, the inhibition of these deep-seated pediatric reflexes goes away, and so they cease to be inhibited, and so they come back so they can be examined for. You're not ever going to be able to make a diagnosis of a specific neurodegenerative problem on the basis of the presence or the absence of these reflexes, but it's just adding additional pieces to the puzzle. So if these reflexes are present, that could be supportive of the patient having some form of neurodegenerative process present. Then we go into the cranial nerve examination. And of course, you're doing a full cranial nerve examination, but some of the things in particular that you're looking for in the extrapyramidal context is firstly anosmia or hyposmia. And that's something that you might forget to examine and you might forget to ask for. And I don't routinely examine this beyond the extrapyramidal context, but if you're seeing a patient with Parkinson's disease, it is good to ask about that and examine for that. Then cortical visual field deficits and neglect are important for CBD, in particular, corticobasal degeneration. Then ophthalmoparesis testing is important, and particularly we're interested in vertical gaze, and in particular, we're interested in downwards vertical gaze. So I was meaning to mention this in the cranial nerve episode, but I forgot to mention it. It's not uncommon for normal elderly patients to have partially or very restricted up gaze. You'll notice this in your daily practice if you're just doing ophthalmoparesis examinations on a geriatrics ward. It's really, really, really common that as we get older, our up gaze decreases, and that is not necessarily pathological in its own right. It's very common and it doesn't mean much in isolation. However, impaired downwards gaze is much more specific as being an extrapyramidal problem, which can be seen in a number of extrapyramidal conditions, but it is especially important when considering PSP, progressive supranuclear palsy. And actually, the supranuclear in PSP is referring to the supranuclear control centers for vertical gaze. So it's actually referring to, it's in the name of PSP that there is this supranuclear problem. There's this problem with the coordination of vertical gaze centers, so the patient can't look downwards very well. Other things that you can look for when you're examining eye movements is saccadic intrusions. So that's when you're doing your cranial nerve examination and you're testing slow, smooth eye movements. Perhaps that's horizontal or vertical, doesn't matter too much. And instead of being a nice smooth movement, it appears jerky. So there are these saccadic intrusions into what should be a smooth pursuit. I will say that this is very, very non-specific. So you're not going to be able to make a diagnosis of a particular condition based on the presence of this sign But similar to the reemergence of the primitive reflexes, it just is an additional piece of the puzzle that builds the case for this patient having an extrapyramidal syndrome. One other thing that you can look for, which is often forgotten about, is a reduced blink rate. So the number to remember is 20. So if the patient is blinking 20 times a minute or more, then that's okay. But if they're blinking less than 20 times per minute, then that's consistent with reduced blink rate. And that can be seen in Parkinson's disease and in some other extrapyramidal conditions. Then one other classic finding in Parkinson's disease is hypomimia, or a masked facies. So that's a patient who has a relatively expressionless face. So they don't have weakness of the seventh nerve per se. So or the muscles controlled by the fifth nerve. So when you're testing for the fifth and the seventh nerve, they should still be able to move the face. But you should be taking note of, during the history and during the examination, does the patient seem to have a socially appropriate range of facial expressions when they're communicating and when they're reacting to things that you're saying? And if they just have a full-on poker face the whole time, then that's what hypomimia is. So they're just completely non-reactive, or it appears that they're non-reactive in the muscles of facial expression, as if they're holding a royal flush in their hand and they're doing their absolute best not to tell their opponents that they've got a winning hand, so they've just got their best poker face on. So that's what hypomimia is. Also, when examining the fifth nerve, you could have tactile loss or neglect in the context of corticobasal degeneration if there is cortical sensory problems in the somatosensory cortex or in the parietal lobe controlling neglect and inattention, especially the non-dominant parietal lobe when it comes to neglect. In addition to hypomimia, you also want to think of hypophonia. So that's a soft voice. And also bradykinesia when it comes to speaking, so verbal bradykinesia. So these things should become obvious when testing the 9th, 10th, and 12th nerves. So when you're testing the bulbar nerves that come off the medulla as part of your normal cranial nerve examination. And it's also important to take note of dysarthria and dysphagia with a G at that time, because they are also features of Parkinson's disease in advanced stages or in the Parkinsonians plus syndromes. Also, dysphonia is important to take note of. Moving on to the upper limbs now. Of course, you're doing a full upper limb examination, but some of the things to take particular note of are, with inspection, does the patient have a rest tremor? And if so, is it asymmetrical? So rest tremor is one of the core diagnostic features of Parkinson's disease, and typically it is asymmetrical. In the later stages of the disease, it may be that the asymmetry is less apparent or it goes away completely once it really does just become bilateral. But in the early stages, it should usually be asymmetrical. And conversely, if there's symmetry right from the beginning, then that may suggest a competing extrapyramidal syndrome, such as one of the Parkinsonian plus syndromes or perhaps a secondary Parkinsonian syndrome. Classically, the tremor has the morphology or the semiology of a pill rolling tremor. So it looks like the patient is rolling a little pill in their fingers. So the second through fifth digits adducted, and then the thumb MCP moving in between opposition and non-opposition to roll a pill in between the fingers. You don't always see that classic pill rolling tremor. There can be lots of other types of tremor, and it often involves the wrist, and it can involve other joints in the upper limb as well. But just so that you know, if someone says pill rolling tremor, that's what they're referring to. Then importantly, very, 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 very importantly, you need to examine for bradykinesia and also decremental hypokinesia. So how do you do that? So we're talking at this point in the examination in terms of hand movements, and there's a few different ways you can do it. I like to do it with finger movements, and one way that I like to do it is by making big crocodiles. So if you're watching on video, you can see it easily. If you're just listening along on podcast, I'll describe it. So again, the second through fifth digits are adducted, and then you're using that as the top of the crocodile mouth, and then your thumb is the bottom of the crocodile mouth, and then you're just flexing and extending the MCPs of the second through fifth fingers repeatedly to make a big opening and closing crocodile mouth. And the key is, I say, make a big crocodile, good. And then what you say is, now keep giving me some more crocodiles opening and closing, but keep them big. So what you don't want to do is you don't want the patient just to do lots of little ones like this. You say, keep them big, keep the crocodiles big. And then you say, good, keep that going, but now do it as fast as you can. So big and fast, big and fast, big and fast, big and fast. So that's the way I coach the patient. So you want them to be big and fast, and then you see what happens. And if the patient really slows down, or if they develop decremental hypokinesia, so they might stay fast, but the amplitude of the movement may progressively decrement so that they're just doing little ones by the end, then that is abnormal, and that's consistent with Parkinson's disease or with some other extrapyramidal problem. And again, asymmetry is a pretty important, in fact, it's a very important factor to look for here. So classically, especially in the earlier stages of typical Parkinson's disease, there will be asymmetry, and it should be the same side which is involved in terms of the rest tremor and also in terms of the tone, which I'm going to get to next. Now on to tone. So tone in the context of an extrapyramidal syndrome like Parkinson's disease should be increased. So it should be hypertonia, P-E-R tonia. And as I mentioned, extrapyramidal hypertonia in the context of Parkinson's disease should be of the lead pipe variety. So it's rigidity. And what that means is that it's velocity independent. So it doesn't matter whether you move the joint quickly or slowly, the tone should still be increased the whole way through, in contradistinction to an upper motor neuron lesion affecting the pyramidal tracts, the corticospinal tracts, which conversely causes a velocity-dependent hypertonia or a spastic or clasp knife hypertonia. So just to reiterate, the increased tone in Parkinson's disease and related extrapyramidal conditions is rigidity, described as a lead pipe rigidity. And if there is a superimposed tremor, then the patient may have cogwheeling. As I mentioned just a moment ago, we're also looking for asymmetry in the increased tone, just as we are looking for asymmetric bradykinesia or decremental hyperkinesia or an asymmetric tremor, all in the same arm in the context of typical Parkinson's disease, especially in the early to mid stages of the condition. Now, in terms of increased tone and also in terms of the tremor, if they're not immediately obvious, then distraction can help to bring these out. So what does that mean? I like to do it by asking the patient to move their head side to side. So just laterally rotating the head to the left and right, back again. Or conversely, other things you can do is ask the patient to draw circles with their contralateral arm, like this if you're watching on video. Or you can ask the patient to perform some form of cognitive demanding task, such as stating the months of the year backwards. And often in early cases, there may be no tremor and no increased tone at rest, but then with this distraction, whatever distraction maneuver you choose to go with, it then brings out the tremor and it brings out the increased tone. And that's a really important point to know about. Now, in terms of your power and sensory testing, including neglect, that's predominantly relevant for some of the Parkinson's plus syndromes, such as CBD. Coordination is especially relevant for MSA, multiple systems atrophy, because, of course, ataxia is one of the core components of MSA. And then other secondary features of Parkinson's disease you can look for here is micrographia. So give them a pen and some paper and ask them to write a sentence. And if the patient has very, 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 very small handwriting, then that is typical of Parkinson's disease. And of course, you'll be taking note in your inspection as well of any obvious dyskinesias that may be emerging as a treatment side effect if the patient is on treatment. So especially if they're on levodopa or similar and they're excessively on and they have dyskinetic, so excessive hyperkinetic movements, not just a tremor, but dyskinesias, then that's very important to take note of. This is the last slide in this talk, so a bit of a shorter talk today. We're now onto the lower limbs. What are we looking to examine here, specifically in the extrapyramidal context? Firstly, we're looking at stance. So that's what it normally would include, but in addition, in this context, we're doing retropulsion testing. And that's a test for postural instability, which you'll remember is one of the 4 core components of Parkinson's disease. So how do you actually measure, or how do you examine for postural instability? You get the patient to stand up, not next to a bed or a wall or anything like this, so there needs to be plenty of space. You ask them to stand so that they feel comfortable and secure, so you're not getting them to stand with their feet together or any funny, weird position. They're just standing with their feet apart. And I would always tell the patient what I'm going to do before I do it so that it doesn't freak them out, because you're not trying to freak the patient out. So you say, what I'm going to do shortly is I'm going to stand behind you and I'm going to give you a quick jolt backwards. So I'm going to pull on both your shoulders and pull you backwards quickly in a deliberate attempt to make you unstable. And what I want to see is if you are able to correct yourself so that you can take a corrective step to prevent yourself from falling over. And you say, don't worry, I'm not going to let you fall. I'm standing behind you. So if you are unable to correct yourself, I will catch you so you will not fall. Don't worry. And obviously, if you have a very obese patient or a patient who's much larger than you, then you have to make sure that you're doing it safely. So if you as the examiner are a very small person and your patient is very big, then you might need someone to help assist with this, because obviously you don't want the patient to fall. So this is essentially a way to assess the patient's balance system in a fairly integrated way to see, is this patient able to prevent themselves from falling over? So you then stand behind them, you've given them the warning, and then you pull them back. And a normal response would be the patient is just able to correct their balance and lean forward a bit and correct the shift in the center of gravity and not fall over. Or they should be able to just take a single step back with one foot to widen their stance, widen their base of support, and not fall over. So that's what a normal response would be. An abnormal response is the patient cannot make that correction, and so they take a step back, and then their center of gravity is still behind them, and they're still falling backwards, and then they take a second step back, and a third and a fourth, and they're clearly not winning, and they're about to fall backwards, and then you have to support them and catch them to stop them from falling over, and that would be an abnormal or a positive test for retropulsion testing, and that's supportive of a diagnosis of Parkinson's disease in particular, or other extrapyramidal syndromes. Then in terms of the actual gait assessment, some of the specific things that you're looking for, typical of Parkinson's disease, would be a stooped posture, a bradykinetic gait, typically with festination. So what's festination? That's when someone starts slow with their walking. So they start with slow, small steps. And I should say a shuffling gait is also typical of Parkinson's disease. But in terms of the festination, they start with slow, small shuffling steps. And then once they get going and they warm up, then they become faster. So the velocity that the patient is traveling at increases, so they accelerate with time. So that's what festination is. Another classic finding is freezing based on environmental cues, and the classic one would be door frames. So the patient's walking along okay, and then they get to a door frame and then they freeze in the door frame and they find it difficult to navigate through the door frame and continue walking. I'm not talking about opening a door which is closed, it's an open door frame, but it's just the environmental cue of the door frame which prevents the patient from continuing to walk through it. And sometimes there are ingenious tricks that can be employed to help in terms of the management of Parkinson's disease, which our occupational therapy and physiotherapy colleagues are excellent at advising us on, in terms of having laser pointers and targets and lines on the floor and such to give a stimulus for the patient suffering from Parkinson's disease with significant gait freezing from environmental cues to have something to focus on to overcome that environmental cue and then keep going. Another gait feature that you're looking out for is something called turning en bloc, or also known as turning in numbers. So that means when the patient stops walking and then they turn around to walk back to you, so they're going through 180 degrees. A normal response would be to be able to pivot on one foot and do the 180-degree turn just in one movement, or maybe pivoting on one foot onto a second foot in order to make the 180 degrees, so in one or two movements. Whereas a patient with Parkinson's disease may not be able to do that, and instead they need to take multiple small corrective steps to make the 180 degrees. So maybe they have to make little 10-degree increment turns, and it takes them 18 steps to get through the 180 degrees, for instance. So these little quick shuffling turns Kind of like doing a 3-point park, but doing a 20-point park to reverse into a parallel park rather than just doing it in nice one fluid motion. One of the other components in gait that you're looking for is reduced arm swing. And you guessed it, again, we're particularly looking for asymmetrically decreased arm swing in the context of early to mid-stage Parkinson's disease. And the reduced arm swing is typically on the side of the body which was more affected in terms of the rest tremor and the increased tone and the bradykinesia. One other gait pattern to be aware of in an extrapyramidal context is a patient with a magnetic gait. And this is the classic description of the gait in a patient with normal pressure hydrocephalus. And this is a very, very important diagnosis not to miss. And that's because it is treatable and reversible completely if you make the diagnosis soon enough and you treat it soon enough before the damage has been done and before it becomes irreversible. So you do not want to miss a diagnosis of NPH because you then miss the opportunity to intervene and cure that patient before permanent, irreversible damage has been done. Distinguishing NPH from Parkinson's disease or other extrapyramidal syndromes is not always straightforward, especially because some of the clinical features can overlap to some extent. So the gait in NPH is this magnetic gait. So it's as if the patient's walking on a magnetic floor and they're wearing shoes which are magnetic. And so it's like their shoes are glued to the floor. So when they're walking along, it's like they barely even clear the floor at all. And it's like they're shuffling along, but like they're glued to the floor. And it's really hard just to get their foot off the floor to take the next step. That can look a bit like or a lot like a shuffling gait of a more typical Parkinson's disease, but it is a bit different. And there are some differences between a typical Parkinson's gait and a magnetic gait of NPH. And hopefully I have done my best to try and describe the differences in the gait there. If you are thinking about normal pressure hydrocephalus, it's worthwhile revisiting the clinical triad and the mnemonic for the clinical triad for NPH at this point. So it is wet, wobbly, and wacky. The 3 W's: wet for urinary incontinence, wobbly for the gait disturbance, which I just described with associated falls, and wacky is a bit of a mean way to describe the cognitive impairment that comes along with NPH. And then you do your neuroimaging and you're looking for features of normal pressure hydrocephalus. So that's hydrocephalus with distinctive neuroradiological features. So usually that means the way to think about it is it's as if the sylvian fissures and the lower parts of the brain, the cerebrospinal flexus there, are expanded, excessively large. But then it's as if that's pushing up, so you don't get the same degree of dilated extraaxial CSF spaces around the vertex. So it's as if it's pushing up. That's how I remember it. So you get big sylvian fissures and big CSF spaces lower down, but then you get gyral crowding or sulcal effacement up near the vertex. And the radiological indices that you look at are the callosal angle, measured in the coronal plane on a CT, or better still on an MRI. So you're looking at the angle which is created by the lateral ventricles. And if you have an acute callosal angle, so less than 90 degrees, then that's indicative of normal pressure hydrocephalus. And the other indice that you're looking at is the Evans index. So that's measuring the widest point between the left side of the frontal horn of the left lateral ventricle and the right side of the right wall of the right lateral ventricle. So you measure that diameter, and then you measure that as a ratio to the diameter of the cerebrum at the same level. And then you calculate that as a ratio and calculate the Evans index. And if that number is large, above a particular threshold, then that's also indicative of hydrocephalus and suggestive of normal pressure hydrocephalus. It's important to recognize that the neuroradiological features of NPH, normal pressure hydrocephalus, really are not very specific. So it's not uncommon to see a CT and it's reported as consider a diagnosis of normal pressure hydrocephalus if it clinically matches, and it just doesn't clinically match at all. So we do lots of CT scans and MRIs, and a lot of them kind of look like NPH, and the patient doesn't have NPH. But it's really that combination of the classic clinical triad, or at least most of the classical clinical triad, and ideally matching neuroradiology. And if you're seriously considering the diagnosis, then there really is an imperative to evaluate for that further with a TAP test usually. But I think I've said enough about that for this episode. Got a bit sidetracked there, so let's move on. So we've just spoken about stance and gait. Let's move on to the other components of the lower limb assessment. So rest tremor and tone. Of course, you're evaluating for these as well, although they're much less involved typically than the upper limbs in Parkinson's disease and other extrapyramidal syndromes, especially in the earlier stages. Again, power and sensation are important, including neglect, especially relevant in some conditions such as CBD. And then coordination is particularly relevant for MSA, just as it was in the upper limbs. And again, you're assessing for any dyskinesias as evidence of a treatment side effect, just as you were in the upper limbs. So that was it for today. Thank you for tuning in. If you did find this episode useful, please like, comment, and subscribe. It really, really helps the project as a whole. Visit our website at rneurologyeducation.org for all of our media formats and additional content. Find our video presentations on YouTube and our audio podcasts wherever you listen to your podcasts, and join us on your preferred social media platforms, all at the domain rneurology education. And email us on contact@rneurologyeducation.org with any questions or to subscribe for updates when new content is released. From cortex to curiosity, this has been Riisfeldt Neurology Education. Until next time, keep calm and synapse on.